In our decision-making today about what to do for the adjuvant or neoadjuvant treatment of early-stage breast cancer, there are many things that we are considering. First of all, should we use a genomic assay to help make a decision about whether chemotherapy is warranted in patients who are at somewhat higher risk, for example, those that are young and have lymph node positive disease. And there are cases where that is appropriate, particularly when those patients are strongly estrogen and progesterone receptor positive and maybe have a lower grade tumor. So more favorable biology, but worse anatomy in terms of the size of the tumor or the number of lymph nodes that are involved. We also have to make a decision in lymph node positive patients whether they should have postoperative radiation therapy if they undergo a mastectomy. And in general, it is recommended to consider for 1 to 3 lymph nodes that are positive, but certainly not all patients who have 1 or 2 or 3 lymph nodes positive should get post-mastectomy radiation. And we can use biologic features as well as clinical features to sort those women into who is more likely to benefit versus those that are not. If we're giving chemotherapy or not, all women who have estrogen-positive cancers tend to get adjuvant endocrine therapy. And an important decision in younger premenopausal women now is whether or not to offer them ovarian suppression plus an aromatase inhibitor as compared to tamoxifen, which is the standard of care for premenopausal women who are at lower risk. The soft and text trials, where we have long-term follow-up now of over 8 years, show the benefit of ovarian suppression in patients who are at high risk. And that can be defined in general. If you think they need chemotherapy, those are the patients who benefit from that more intensive endocrine therapy of ovarian suppression plus an exemestane or another aromatase inhibitor. Conversely, patients who have lower risk premenopausal estrogen-positive cancers do very well with tamoxifen alone. Finally, we talked about the toxicities of both chemotherapy, but particularly endocrine therapy. And there are substantial toxicities for premenopausal women, especially if we're adding ovarian function suppression. They become chemically menopausal abruptly, and that leads to vasomotor symptoms and musculoskeletal symptoms. Many of these women actually go off the therapy because it's hard to deal with. So a very important factor in treating patients with more intensive adjuvant endocrine therapy is to make sure you know of all their symptoms, and the fact that there are multiple pharmacologic and non-pharmacologic interventions that can help them get over those toxicities and help them sustain their therapy. We then have the final decision, which is whether or not to continue adjuvant endocrine therapy beyond the 5 years. And we now have a number of studies that have shown for women who are at higher risk, there is benefit. It's modest, but there's real benefit in 10 years of adjuvant endocrine therapy over 5. And we now have genomic classifiers that will also help us not only tell about the prognosis of long-term endocrine therapy, but also predict whether or not extended adjuvant endocrine therapy is worthwhile.